Hello, in this video lecture, we're going to be walking you through the process and the terms to use the Solventum encoder to assign MS DRGs. A couple of key terms that you'll need to know. First is the base payment rate, and this is the rate that is paid for each discharge for operating and all capital-related components for an acute care hospital stay. So these are facility charges. This is what the hospital gets paid, and it's related to the base payment rate. The comorbidity complication and major comorbidity complication exclusion lists are a set of principal diagnoses that are related to a comorbidity complication, a CC, if you will, or a major comorbidity complication, or MCC, if you will, code, that takes away the refinement power of the CC or the MCC for a particular hospitalization or encounter. When we use the term CC, of course, we're talking about complication and comorbidity. And these are diagnoses codes that when they're reported as secondary diagnoses, they have the potential to impact the MS-DRG assignment by increasing the MS-DRG severity up one level. And if you think about it, it makes sense. So if you have a secondary complication or comorbidity that complicates the hospital stay, it's more resource intensive, so the hospital gets paid higher and should have a higher MS-DRG. The grouper is a computer program, as you'll see, that uses specific data elements to assign patients, clients, or residents to groups, categories, or classes. So in other words, if somebody is having hip replacement surgery for osteoarthritis versus somebody who's admitted for an acute MI, that's going to be a different MS-DRG. So the resource usage will be different for the hospital. So you're going to group like diseases and conditions together. That's the intent. The major complication and comorbidity, the MCCs, are diagnosis codes that are similar to what we saw in the CCs, the complication comorbidity. However, when these diagnosis codes are reported as secondary diagnoses, they move the MS-DRG assignment up one or two levels. And these are the more significant secondary diagnoses that affect the reimbursement. As you probably have gathered by now, the major diagnostic category of the MDC is the highest level in the hierarchy of the MS-DRG inpatient prospective payment system. So what is it about the MS-DRGs? Well, DRGs have been with us since the 1980s. And the Medicare severity is a way of parsing out a DRG so it allows payment to be more closely aligned with resource intensity. The MS-DRG family is a group of MS-DRGs that have the same basic set of principal diagnoses with or without operating room procedures. The principal diagnosis, which is one of the things that drives the MS-DRG, is the reason established after study to be responsible for the patient being admitted to the hospital for care. And then the relative weight is the weight that reflects the resource consumption associated with the payment classification or group. Higher payments, of course, have a higher relative weight. And again, the steps, we have the pre-MDC assignment, the major diagnostic category determination, whether the patient has had medical or surgical determination, and then the refinement. It's vitally important for HIM professionals to be proficient in these steps so they understand why some admissions are assigned to particular MS-DRGs. So the MDCs are covered in the text. And some examples of these are the things that we commonly group disease categories. And these might be grouped by body systems like O1, diseases and disorders of the nervous system, O5, diseases, disorders of the circulatory system, and so on. And these are in your textbook on table 5.2. Most MSDRGs are assigned based on the principal diagnosis or combination of the principal diagnosis and a procedure. However, there's certain procedures that are used to assign the MSDRG rather than the principal diagnosis or a combination of the principal diagnosis and the procedure. That's why you need to read the entire record carefully and apply it and use the grouper. The grouper takes a lot of the legwork out of this. So please, I will let you guys review tables 5.4 and 5.2 in your text. And then here's an example of what we're talking about. We have the principal diagnosis, and the principal diagnosis will place an admission into one of the 25 MDCs. And again, important thing to bear in mind, we only have principal diagnoses for hospital inpatient stays, and that's the reason established after study to be responsible for occasioning the admission of the patient to the hospital. In other words, it's the reason for admission. Appendix B of the MSDRG definitions manual has the link between the diagnosis code and the corresponding MDC, as you can see here. And you see some more examples in 5.3 in your text. And the next step is to determine if an operating room procedure was performed. And you can view that in Appendix E of the MSDRG definitions manual, where it lists OR procedures. Some of these are not actually performed in the OR. Some examples are the stem cell and bone marrow transplants. And some procedures group to several MSDRGs. You can see an example of it here. The determining factor to choose the right MSDRG is the principal diagnosis. So you could use shunts and other certain procedures for a number of different principal diagnoses. That's where the rubber meets the road. And the procedure does not have to be the principal procedure to influence the MSDRG assignment. The OR procedure can be any of the ICD-10 PCS code slots on the claim. And then finally, we have the refinement. This is the last step before the final MSDRG assignment. And again, most commonly, we want to make sure that we're picking up all those CCs or MCC secondary diagnoses. And again, this is why you read the entire record. We want to make sure that we're coding everything to the highest level of specificity. The grouper will also help group these and sequence them appropriately. Here's an example that gets lost on some people. We have a cardiac defibrillator. If you look up here, it can be with a catheterization, with an AMI, heart failure, or shock with a major CC. So that would be 22205. And then 22305, notice that it's somewhat different. We have the defibrillator implant with the catheterization, with an AMI, with heart failure or shock, but without an MCC. So the first refinement question is, was a cardiac cath performed? If yes, then as you can see from this table here, the MSDRGs would be 222 through 225. If it's no, then the only ones that it could be would be 226 through 227. And then the second refinement is, did the patient have one of these MCCs? In other words, did they have the AMI, heart failure, or shock? Again, if it's yes, it's 222 through 223. If no, then it's either 224 through 225. And then finally, is the MCC diagnosis a secondary diagnosis? If it's yes, then it's either MSDRG 222, 224, or 226. And if it's no to that MCC being a secondary diagnosis, then it has to be either 223, 225, or 227. And notice that all of the 223, 225, and 227 are without the MCC. And that's all I have for you. In the next video lecture, we'll talk about how we can use the Solventum encoder to assign MSDRGs and have accurate ICD-10 CM and ICD-10 PCS coding. We'll see you online. Bye now.